صباح الخير جميعا، ونتمنى تكونوا جميعا بألف خير وصحة وسلامة يا رب انتوا جميع الأهل. اليوم موضوع محاضرتنا Oral Embryology II Early Tooth Development. مواضيع المحاضرة تشمل Tooth Development Phases, Initiation, Morphogenesis, Histogenesis, Stages of Tooth Germ Formation, bud stage, cap stage, early bill stage, late bill stage, transitory structures, enamel knot, enamel cord, enamel niche, root formation, epithelial mesenchymal interaction, and some clinical considerations. First, we start with the phases of tooth development. First phase is the initiation phase. In this phase, the locations of teeth are established with the appearance of tooth germs. Tooth germs appear along the dental lamina, which is an invagination in the oral mucosa. Second phase is the morphogenesis. Morphogenesis means the formation of shape. Shape of teeth is determined in this phase. Cell proliferation and movement determine the shapes of teeth. Third phase is histogenesis, and histogenesis means differentiation. Differentiation of cells take place to produce the fully formed dental tissues. Histogenesis begins during morphogenesis as all phases are overlapping. Means each part of the tooth, of the future tooth, that finished its morphogenesis, straight away it starts to differentiate or undergo histogenesis to start to secrete hard tissues, enamel, dentine, and cementum. So, for example, the crown, when the shape of the crown is determined, the secretion process, the differentiation process starts in the crown region without waiting till the root is formed. Then the root is formed, which means morphogenesis of the root. Then the morphogenesis of the root is followed by histogenesis. And each area that finished morphogenesis starts histogenesis straight away. Doesn't wait until all the other parts finish their morphogenesis. Tooth development in the primitive oral cavity, mesenchymal condensation underneath the dental epithelium takes place. Ectodermal in origin, migrated from the margins of the neural tube. To explain that, we have the oral ectoderm inside the oral cavity. Underneath the oral ectoderm, we have ectomesenchyme. Ectomesenchyme means it's a mesenchyme, but it's derived from the neural crest cells. The neural crest cells are the cells that formed at the crest of the neural fold. The crest of the neural fold is the boundary between the neural and non-neural ectoderm. They form there, then migrate and populate many areas of the body, especially in the head and neck region. So that's why it's called ectomesenchyme, because it's a mesenchyme, but it's not derived from the mesoderm layer. It's derived from originally from the ectoderm layer. So that's why it's termed ectomesenchyme. Do we have a role of the endoderm, it's questionable. If there is a role for the endoderm, it would be in the most posterior region of the oral cavity. Maybe in the formation of third molars, maybe they are involved, maybe not. But in the rest of teeth, it's unlikely for the endoderm to have a role. So the initiation of development of teeth, there should be interaction between the overlying oral ectoderm and the underlying ectomesenchyme. This is termed epithelial mesenchymal interaction. It's very important for the initiation process. There is no interaction, no initiation, and no tooth formation. This is a very important stage. Now we'll talk about the stages of tooth development week by week. During week 6, we see that there is local thickening of the oral ectoderm. This area here, this area here. So the oral ectoderm thickens. When it thickens, it means it's more active. It's undergoing interaction with the underlying tissue. And the underlying tissue will start to condense, which is the ectomesenchyme. So we have thickened oral ectoderm. Underneath it, we have condensed ectomesenchyme. Both of them are active at this stage. They are undergoing interaction, sending messages back and forth to the other layer. So this is the initiation period. Invagination of the epithelium into the mesenchyme to form primary epithelial band. At this stage, where we see thickened oral ectoderm and a slight invagination toward the ectomesenchyme, this stage is called the primary epithelial band stage. Same thing here. We have here primary epithelial band, week 6, primary epithelial band, week 6. We see thickening of the oral ectoderm. We see condensation of the underlying ectomesenchyme. And notice that we see a cell-free zone between them. Whenever you see a cell-free zone, means there is interaction between the two layers. The week after, which is week 7, we see that the primary epithelial band invaginate deeper and divides into two laminae. One is called vestibular lamina, which is here, and one is called dental lamina, which is here. Vestibular lamina located buccally. Vestibular lamina located buccally, and dental lamina located lingually. This is the tongue here. So the dental lamina closer to the tongue, vestibular lamina away from the tongue, closer to the lip and cheek. The vestibular lamina is involved in the formation of the vestibule, which is the area separating the future tooth-bearing region from the face, including lip and cheek. The dental lamina is the one that's involved in dental development and the formation of teeth. During week 7, we see that the end of the dental lamina is not oval yet. When it's oval, it's called bud stage. This happens during week 8. In week 7, the end of the dental lamina doesn't have a particular shape. So we can't identify a particular shape at the end of the dental lamina. The vestibular lamina contributes to the development of the vestibule. Vestibule delineates the lip and cheek from the tooth-bearing region. Degeneration of central epithelial cell producing a sulcus. Sulcus same as vestibule. So the vestibule first is formed as a solid sheath of epithelium, which is called vestibular lamina. Then the central epithelium degenerates to form the sulcus or the vestibule. The dental lamina contributes to the formation of teeth. Here we are looking at the sagittal section, showing here we see the tongue, here we see the mandibular process, here we see upper lip, lower lip, Meckel's cartilage, developing mandibular bone. Here we see vestibular lamina. Here we see dental lamina. And notice the end of dental lamina. We have a shape here. At the end of dental lamina, a shape that looks like a hat. This is called cap stage. We will talk about it in a minute. But this is to show you the relationship between the vestibular lamina and the dental lamina. Vestibular lamina labial in this case, because we are in the lip region. Dental lamina is lingual, closer to the tongue. Same thing, but more magnified. See vestibular lamina, dental lamina. The dental lamina, the end of the dental lamina have a hat-shaped structure. So it's called the cap. This is called cap stage. But we will come to the details of that in a minute. Notice that the vestibular lamina here is a solid sheath. Not yet, no central degeneration yet. It should grow to its full depth. Then starts the central degeneration. Now we move to week 8 in utero, of course. Here is the dental lamina. Here is the vestibular lamina. But focus here at the end of the dental lamina. We have an oval structure. This is called the bud stage. Bud stage, when the end of the dental lamina is oval. This is week 8. When you identify the oval structure at the end of dental lamina, then it's week 8. Swelling develop on the deep surface of the dental lamina. Each swelling is surrounded by mesenchymal condensation. You see the tooth bud here is surrounded by ectomesenchymal condensation. Means more interaction is taking place. The more condensation, the more interaction. Tooth germs are classified into different stages depending on the shape and the state of development of the end of the dental lamina. So all depends how the end of the dental lamina looks like. First stage, the bud stage. The end is oval structure. Then cap stage. The end looks like a cap. The end of the dental lamina. Early and late bill stages. The end of the dental lamina looks like a bell. Early or late depending on whether there is secretion or no secretion of hard tissues. Early bill stage, no secretion of hard tissues yet. Late bill stage, same shape, but plus we have secretion of hard tissues, enamel and dentine, in the crown. This is only for descriptive purposes, as odontogenesis is a continuous procedure without different stops. So sometimes you see sections where the shape is not, it's in between two stages. For example, you may identify some slides, in some slides the end of the dental lamina is between oval structure and a cap. It's a transitory stage because this is a continuous process. It doesn't change abruptly from bud to cap. There is always something in between. Bud stage. This is bud stage. This is also bud stage. Oval structure. Notice that the length of dental lamina is variable. So not in all slides you see the same length. This is long dental lamina. This is short dental lamina. We do not care much about the length of the dental lamina for staging. The staging depends of the end of the dental lamina. The enamel organ appear as a simple ovoid epithelial mass. So from now on, the end of the dental lamina, starting from the bud stage, is called enamel organ. And the enamel organ starts as oval structure in the bud stage. In the cap stage, become cap-like. In the bill stage, early or late, it looks like a bill. The enamel organ appears as a simple ovoid epithelial mass surrounded by mesenchyme. Mesenchyme separated from epithelium by basement membrane. The enamel organ is epithelium. It's the end of the dental lamina. And the dental lamina, where it comes from? It comes from the oral ectoderm, so it's epithelium. Underneath the enamel organ, or surrounding the enamel organ, we have ectomesenchyme. Always when you have epithelium and mesenchyme, there should be between them basement membrane. Basement membrane. Now we move to the next stage, the cap stage. And we actually have two cap stages. One is called early cap stage and one is late cap stage. Early cap stage is during week 11. You see here cap stage 11 weeks in utero. Because we have cap stage 12 weeks in utero. One is early, one is late. The end of the dental lamina, the enamel organ, now looks like a hat, cap. And this part of the cap is straight, this part. See this part? It's almost straight. This is in week 11, early cap stage. Because in the week after, late cap stage, this part become arc-shaped. So both are hats, but two different shapes of hats. straight, when this part is straight in this early cap. Same here as well. See here, this part is straight, so it's early cap, week 11. Morphogenesis, progress, invagination of the deeper surface of the enamel organ. Peripheral cells starts to be arranged as external and internal enamel epithelia, central cells more rounded. Now at this stage, starting from the early cap stage, we can identify 3 types of cells within the enamel organ. We see this type of cells. This is one type in this area here. The other type is here. The other type in the center. This type is called internal enamel epithelium or inner enamel epithelium, or internal dental enamel epithelium, or inner dental enamel epithelium. The epithelium here is called outer enamel epithelium, or external enamel epithelium, or external dental epithelium, or outer dental epithelium. You can, any of these names are okay. Central part epithelium is called stellate reticulum. And each kind of these 3 types have a special morphology. The internal epithelia are columnar. Outer enamel epithelia are flat or cuboidal. Stellate reticulum are star-shaped cells with many intercellular spaces in between. And these intercellular spaces are filled with fluids. Okay. Peripheral cells start to be arranged as external, internal enamel epithelia, central cells more rounded, and these central cells are called stellate reticulum. Now we move to next week, week 12. So we have cap stage 12 weeks in utero, means late cap. Notice that this part of the enamel organ is arc-shaped now. In the early stage, it was straight like this. And now, it's arc-shaped. This is the internal enamel epithelia part. Internal enamel epithelium become arranged in arc shape during the late cap stage. Central cells in the enamel organ become separated by stellate reticulum, cuboidal external epithelia, columnar internal enamel epithelia, proliferation of the surrounding mesenchyme. And now we can identify 2 parts of the ectomesenchyme. We can identify the dental papilla and the dental follicle. Both of them are ectomesenchyme, so they are outside the enamel organ. This part is called dental papilla. It's in close interaction with the internal enamel epithelium. So it's underneath the internal enamel epithelium. This internal enamel epithelium, underneath the ectomesenchyme, underneath is called dental papilla. Dental follicle is it's like a sac. It surrounds both the enamel organ and the papilla. It's called dental follicle or sac. It's like a bag surrounding the whole structure, and it's ectomesenchyme. The dental papilla will give rise later to the pulp and dentine. The enamel organ will give rise to enamel, and the dental sac or follicle will give rise to cementum, periodontal ligament, and alveolar bone. Here, same thing. We have cap stage late 12 weeks. Identify here the papilla, dental papilla, enamel organ, and the follicle, dental follicle. You see, these columnar cells are internal enamel epithelia. They are in close proximity to the papilla. And notice that we have between them cell-free zone. I mean, there is a lot of interaction going on between the internal enamel epithelium and the underlying cells of the papilla. These cells, the underlying cells of the papilla, will become odontoblasts, and the cells of the internal enamel epithelium will become later on ameloblasts. Odontoblasts secrete dentine, ameloblasts secrete enamel. So when we say the enamel is derived from ectoderm, it's true, because the enamel organ is part of it's the end of the dental lamina, so it's derived from the dental lamina, and the dental lamina from oral ectoderm. So the enamel organ give rise to enamel, so the enamel is derived from ectoderm, from oral ectoderm specifically. And the other parts of the tooth, dentine, pulp, cementum, alveolar bone, periodontal ligament, all of these are derived from ectomesenchyme. So they are not derived from the oral ectoderm. They are derived from ectomesenchyme. The ectomesenchyme is originally from ectoderm, but not the oral ectoderm. It's from the crest of the neural fold. It's derived from neural crest cells, as we explained before. Here, the cells of the internal enamel epithelium columnar, cells of the outer enamel epithelium cuboidal. And always, columnar cells are more active than cuboidal cells. And cuboidal cells are more active than flat cells. The outer dental epithelium, outer enamel epithelium are either cuboidal or flat, while the internal enamel epithelium is columnar, means more active. Then we go to the next stage. It's called early bill stage. It is 14 weeks in utero. Now, first of all, let's identify the main parts. This is vestibular lamina. This is dental lamina. And see now, the enamel organ, its internal enamel epithelium part, it looks like a tooth. It predicts the shape of the future tooth that will be formed by this structure. You see here, although it's a two-dimensional section, If it's three-dimensional, you can predict accurately, but because it's two-dimensional section, it gives you an idea that at least this tooth will be an anterior tooth. You can identify cingulum area here. You can identify lingual fossa here, incisal edge or cusp tip, depending if it's incisor or canine, labial surface, then the labial height of contour here. So you see, you can predict the shape of the tooth. So this is called early bill stage. Early bill stage, when you can predict the shape of the tooth. The folding pattern of the internal enamel epithelium predicts the shape of the tooth. When you see that, then it's early bill stage. The late bill stage is the same, but add to that secretion at the initiation of secretion at the cusp tip or incisal edge, because this could be cusp tip. If we are talking about canine, it could be incisal edge. So if we identify secretions here, then it's late bill stage. But here still we don't identify any secreted material like dentine or enamel. Cell-free zone all the way between internal enamel epithelium and there is no something different anywhere in this area to suspect secretion. At the cusp tip on incisal edge, when there is something secreted, then the cell-free zone will disappear and will be replaced by the secreted material. And you see the nuclei, the dark spots, will be further apart from each other. This row of nuclei, this is another row of nuclei. When there is something secreted between them, they will be pushed away from each other because of the secreted material needs to take space. And we don't see that here. It means that still we don't have secretion. It means that this is an early stage. The shape of the internal enamel epithelium decides the shape of the crown. So the folding pattern of the internal enamel epithelium decides the shape of the crown. Mitotic activity at different sites affect the folding. And this folding pattern then dependent on the mitotic activity. So the variation in the mitotic activity within the area of the internal enamel epithelium. This variation in mitotic activity at different sites of the internal enamel epithelium leads to the shape of folding. Contribution of available spaces and mechanical forces. Also, there is an important factor is the balance between the hydrostatic pressure of the stellate reticulum and the blood pressure within the dental papilla. So this balance is important to maintain this folding pattern. If there is a disturbance, then there will be either evagination like this or invagination. This will be represented as the final product, the tooth. So teeth with evaginated odontomes, extra material formed. This because the blood pressure in the dental papilla is greater than the hydrostatic pressure within the stellate reticulum of the enamel organ. If it's the opposite, then we have invaginated odontome, which is also called descendant. We will explain that in the clinical considerations. But now, just to have an idea, that this balance between these two forces is important. There are many changes taking place in the early bill stage. One of these changes is that we start to see the successional lamina. It's called here permanent tooth bud. It's not very accurate because bud means oval. It's oval, this one here. It's better term, successional lamina. Successional lamina, and this is the dental lamina of the permanent successor. The permanent tooth that will replace this primary tooth. So if this is the primary tooth germ, if this forms a central incisor, for example, primary central incisor, deciduous central incisor, then the successional lamina forms the permanent central incisor, and it's always located lingual to the primary tooth germ. So permanent tooth germ always lingual to the primary tooth germ. This is vestibular lamina toward the face, buccal or labial toward the lip and cheek, and this toward the tongue. Also, we see among these changes the disintegration, the initiation of disintegration of the dental lamina. Initiation of disintegration of the dental lamina. By the way, when we say tooth germ, we are referring to three parts. Tooth germ equals enamel organ plus dental papilla plus dental sac or follicle. We come back to the disintegration of the dental lamina. So this is initiated at the beginning of the early bill stage. When it disintegrates, it leaves remnants of cells, remnants of epithelial cells. These remnants of epithelial cells are called epithelial cell rest of serrase. Epithelial cell rest of serrase. And these are dormant cells. Normally dormant cells. However, sometimes in some people they get activated. We don't know why. They get activated and start to form cysts. Cysts start as keratin-filled cysts called serrase pearls, and when they grow bigger, they become fluid-filled, and they are called serrase cysts. If they grow very large and they will obstruct the eruption of the tooth, so the tooth cannot erupt. And now they are called, when they are very large and they are obstructing the eruption of the tooth, they are called eruption cysts. They should be removed, surgically removed, to allow the tooth to move. Also, among the changes that take place during the early bill stage is formation of a fourth type of cell within enamel organ. Previously we have three: internal enamel epithelium, outer enamel epithelium, stellate reticulum. Now we have a fourth one, and the fourth one is here, just above internal enamel epithelium. They are flat cells, 2 to 3 rows of flat cells. When you have a higher magnification, we can identify them. This is internal enamel epithelial cells. If you look closely, you see there are flat cells just above them, 2 to 3 rows of flat cells, and they are called stratum intermedium. Stratum intermedium. This layer appears at the early build stage. Also, among the changes during this stage is the segregation of 3 layers of the dental follicle. The dental follicle becomes inner investing layer, middle investing layer, and outer investing layer. Inner investing layer is highly cellular, highly vascular, and will give rise later to cementum. Middle investing layer, less cellular, less vascular, will give rise later to periodontal ligament. Outer investing layer, highly cellular, highly vascular, will give rise to alveolar bone. Dental lamina breaks. The remnant cells are called epithelial cirrus of serrase. Dental follicle becomes inner vascular fibrocellular condensation, loose connective tissue layer, outer vascular lining the alveolus. 4 distinct layers in the enamel organ: external enamel epithelium, stellate reticulum, stratum intermedium, internal enamel epithelium. The new one is the stratum intermedium, and it's here between stratum intermedium and stellate reticulum. Stratum intermedium, columnar cells. Internal enamel epithelium, columnar cells. Stellate reticulum, star-shaped cells. Between them, you see these flat cells. If we go higher magnification, you see these flat cells just overlying the columnar cells. The internal enamel epithelium cells, columnar, overlying them flat cells, stratum intermedium, and here we have stellate reticulum, star-shaped cells. This is the papilla here, cell-free zone. This part of the papilla, the cells in this area close to the cell-free zone, will become odontoblasts and secrete dentine. These cells of the internal enamel epithelium will become ameloblasts and secrete enamel. This is outer enamel epithelium. See, the cells here are flat or cuboidal. Then here we see inner investing layer of the dental follicle. There is no cell-free zone between them. Here you have cell-free zone between inner enamel epithelium and papilla. Here between outer enamel epithelium and inner investing layer of the dental follicle, we do not have cell-free zone. External enamel epithelium, outer enamel epithelium forms the outer layer of the cells in the enamel organ, cuboidal or flat cells. Basement membrane separates the cells from the mesenchyme, which is the dental follicle. Always when you have epithelium and then mesenchyme, there should be basement membrane. They have large central nuclei, small amounts of organelles related to protein synthesis. They have desmosomes and gap junctions. They are considered cells of very low activity. They are not very active cells. Stellate reticulum, outer enamel epithelium, and then we have dental follicle. You notice there is no cell-free zone between them. They are flat and cuboidal, flat or cuboidal. What's the cervical loop? Cervical loop is the area where the inner enamel epithelium meets the outer enamel epithelium. You have inner enamel epithelium here, columnar cells, outer enamel epithelium here, cuboidal or flat cells. This area where they meet is called cervical loop. It's always cervical, that's why it's called cervical loop. Cervical loop is at the growing margin of the enamel organ, lies at the junction between inner and outer enamel epithelium. It has high metabolic and mitotic activity. Stellate reticulum. Intercellular spaces become fluid-filled, star-shaped cells with branching processes, prominent nuclei, little endoplasmic reticulum, and few mitochondria, developed Golgi apparatus and microvilli, suggesting a role in extracellular material secretion. They secrete glucose aminoglycans, and they have alkaline phosphatases. They have mesenchymal-like features with the ability to synthesize collagen. Stellate reticulum, continuing stellate reticulum. Stellate reticulum protects the underlying tissues and maintain tooth shape, balance between the hydrostatic pressure of the stellate reticulum and the papilla is important for maintaining the folding pattern of the internal epithelium and thus the morphology of the tooth. And any imbalance between these two forces, any disturbance will affect the crown outline. Stratum intermedium consists 2 to 3 layers of flat cells, lies over the internal enamel epithelium, as we explained before here. Resembles stellate cells but with smaller spaces. So these cells, although they are flat, but their shape is they have close resemblance to the stellate reticulum cells, but they don't have spaces between them. That's why this layer looks different from the stellate reticulum layer. And these stratum intermedium originate from the stellate reticulum actually. They are a subpopulation of the stellate reticulum, but they don't have spaces between them. They are considered as stem cells. They act as stem cells to regenerate both stellate reticulum cells and to regenerate cells of the internal enamel epithelium. They are also involved in the transport of material between the internal enamel epithelium and the stellate reticulum. So they bring material to the internal enamel epithelium and bring oxygen and other nutrients to the internal epithelium from the stellate reticulum, and they transport waste, carbon dioxide and other types of wastes toward the stellate reticulum from the internal enamel epithelium. Stratum intermedium is concerned with the protein synthesis, helps in the transport of the material to and from the internal enamel epithelium, and also it concentrates material. External enamel epithelial cells are columnar, rich in RNA, and contain no alkaline phosphatases. These cells, as you see, they are columnar. They are very active cells, separated from the dental papilla by basement membrane and a cell-free zone. So, basement membrane here and cell-free zone. During the early stages, dental papilla. This is the dental papilla here. During the early build stage, closely packed mesenchymal cells, few fibrils, and rich in glycosaminoglycans. Now we will move to the late build stage. In late build stage, the enamel organ looks same as in the early build stage. So you can predict the shape of the crown of the tooth. But here we add to it the secretion of hard tissues. So if we magnify this, you see here in the cusp tip or incisal edge region, there is secretion of dentine and enamel. The dentine is light green here, and the enamel is darker in stain. It's overlying the dentine. So when you see secretion, then we are in the late build stage. The late build stage starts at week 18 for primary teeth and for all primary teeth, and it continues until the time point of crown completion. You remember in the chronology tables of dental anatomy, we have for each tooth a first evidence of calcification time point and the crown completion time point. The first evidence of calcification corresponds to the beginning of the early build stage, where hard tissues, which is straight away followed by calcification, starts, and the end of the end of build stage coincide with the crown completion time point. The lingual downgrowth of the external enamel epithelium give rise to the permanent anterior tooth buds. Here they are talking about the successional lamina. Successional lamina, the end of the successional lamina becomes oval, starts to become at the bud stage at week 20, which is 5 months in utero. But the late build stage is early, 18 weeks in utero. So the primary tooth germ enters the late build stage at week 18, and the successional lamina, the end of the successional lamina becomes oval, so the permanent tooth germ becomes bud stage at week 20. So the stage here, depending on the permanent tooth germ, is week 20. The primary tooth germ already started. It has been secreting for 2 weeks now. That's why we see substantial amount of dentine and substantial amount of enamel. If it's 2 weeks earlier, week 18, we can only see the first sign of secretion. Only a very little amount of dentine secreted and not yet enamel, because dentine secretion precedes enamel secretion. Now we have both dentine and enamel in substantial amounts. It means that the primary tooth germ already started the secretion of hard tissues, already started the late bill stage. Dental lamina grows posteriorly to give rise to tooth buds of permanent posterior teeth. The permanent molars, first molar, second molar, third molar, they don't have primary predecessors, so they don't replace primary teeth. So their growth and development is not in association with primary tooth germs. They grow posteriorly around week 16, 4 months in utero. Then the first molar, the permanent first molar, reaches the bud stage at week 20. The second molar reaches the bud stage at 10 months after birth, at the age of 10 months. And the third molar reaches the bud stage at the age of 5 years. So for permanent teeth, all permanent teeth reach the bud stage at week 20, except second molar and third molar, they are exceptions. They reach the bud stage, the second molar, at 10 months of age, and the third molar at 5 years of age. Then each tooth will follow after the bud stage, become early cap stage, late cap stage, early bill, then late bill. Primary teeth are their development precede the development of permanent teeth. Late bill stage is also called a positional stage because there is formation of hard tissues. Dentine always precedes enamel. Hard tissue formation starts at the cusp tip or incisal edge. So not the whole crown starts secreting. The secretion of dentine followed by enamel starts at the cusp tip or incisal edge, then spreads to the rest of the crown until it reaches the cervix of the crown. The cervix of the crown is the latest in development compared to the other parts of the crown. Tail and epithelial cells differentiate into preamyloblasts. Preamyloblasts induce underlying mesenchymal cells of the dental papilla to differentiate into odontoblasts. Odontoblasts produce predentine, which is quickly mineralized into dentine. The presence of dentine, once mineralized, induce the amyloblasts, the overlying amyloblasts, to secrete enamel. So this is the sequence of events. Here we have a tooth germ And notice that this is at late build stage. Why late build stage? Because there is secretion. There is secretion at the cusp tip or inside the lid. This material is dentine, mineralized dentine, newly secreted dentine. It was secreted as a pre-dentine, then it's quickly mineralized into dentine. So this is at the initiation of the early build stage. So this will correspond to week 18. Because it's only dentine. We cannot identify enamel yet. Notice here formation of a keratin-filled cyst from the remnants of the dental lamina from the epithelial cell, rest of cell rays. This is called cell rays. Notice that successional lamina is not yet in the bud stage. It's not a bud stage. So not week 20 yet. Because still we are 18th week. After 2 weeks, this will become oval. Also notice the central degeneration of the vestibular lamina. We can identify central degeneration here. This is magnification of this part, cusp tip or incisor edge. See here dentine. So the cells here underneath the dentine are called odontoblasts now. And the cells overlying the dentine, now they are called preamyloblasts. Preamyloblasts. We cannot call them amyloblasts until we see enamel. So they are just ready. They are part of the internal enamel epithelium, but they are just ready to secrete enamel. Here we have stratum intermedium, flat cells, and stellate reticulum, the star-shaped cells with fluid-filled cells, filled spaces in between. Here we see odontoblasts. This is the rest of the dental papilla. Predentine, dentine, enamel, which is immature enamel at this stage, because mature enamel appears space in decalcified sections. This is immature enamel, appears dark. It has a 20 to 25 to 30% organic material. 25 to 30% organic material, which is enough to maintain the tissue after decalcification. Mature enamel have only 2% organic material. It's 96% mineralized. It has 2% organic and 2% water. And after decalcification of 96%, the whole thing will be lost and the enamel will appear as a space. But the immature enamel stays after decalcification. These cells are amyloblasts. Because you can see enamel, then you call them amyloblasts. Stratum intermedium, flat cells, stellate reticulum. What stage of development? It's late build stage. Is it week 18 exactly? No. Week 18, you only see dentine. no enamel yet. So this is more than week 18, maybe week 20 or week 19, but it's not week 18. Now we'll talk about transitory structures during tooth development: enamel knot, enamel cord, enamel niche. The enamel knot is a localized mass cells in the center of the internal enamel epithelium. It's a collection of cells mainly from the internal enamel epithelium plus cells of the stellate reticulum. It might be bulging to the dental papilla or sometimes not bulging, like in this case here. Its non-proliferative cells determine the location of future cusp tip or incisal edge areas, and they are a signaling center. They have a number of signals in this center, like bone morphogenetic proteins, fibroblast growth factors, sonic hedgehog, and transcription factors. The number of enamel knots correspond to the number of cusps. So if we have 4 cusps, then we have 4 enamel knots. 2 cusps, 2 enamel knots. If we have an incisal edge, then we have only 1 enamel knot. They are mostly identified in the cap stage, during the cap stage, whether early or late cap stage. This one here, in this case, we have an early cap stage tooth germ, and we can identify the enamel knot here. Enamel cord, a strand of cells extending from the stratum intermedium into the stellate reticulum. So you see here letter A. This is called enamel cord, or more specifically we can call it enamel septum, because the enamel septum reaches the outer enamel epithelium. Enamel cord stops before it reaches the outer enamel epithelium. Enamel septum is an enamel cord that completely splits the stellate reticulum. Enamel navel, which is letter B here, is a depression area where the septum, enamel septum, connects with the outer enamel epithelium. The invagination, so the enamel navel is the invagination where the enamel cord meets the external enamel epithelium. Whether cord or septum, they both act as a mechanical tie and a focus for stellate reticulum cell formation. So they are stem cells. Besides being a mechanical tie, they act as stem cells to regenerate stellate reticulum cells. Enamel niche is an area enclosed between 2 septa that form a double attachment to the dental lamina. It's funnel-shaped depression containing connective tissue. So enamel niche can be identified only when we have multiple attachments. Dental laminae. When you have a single dental lamina, we can't see an enamel niche. When you have more than one dental lamina, like in this case here, we have main dental lamina here, and we have 2 lateral laminae. This is called the main dental lamina in the center, and the others are called lateral dental laminae. Between the main dental lamina and any of these lateral laminae, you can identify the enamel niche areas. And they are outside the enamel organ, so the cells within these areas are not stellate reticulum cells, they are connective tissue cells. Also, you can call them ectomesenchymal cells. They are not important. Now we'll talk about root formation. Root formation starts when the enamel and dentine formation are well advanced. The enamel epithelia at the cervical loop forms a double-layered root sheath called the Hertwig's epithelial root sheath. It has no stellate reticulum and it has no stratum intermedium, only internal enamel epithelium and external enamel epithelium. So the internal layer toward the dental papilla, which is now you call it pulp, because odontoblasts already differentiated and started secreting dentine, and they are well advanced in that process. So the rest of the dental papilla can be called the pulp at this stage. So the Hertwig's epithelial root sheath is a bilayered, double-layered sheath that has its internal part as internal enamel epithelium and its external part as external enamel epithelium. It's like a sheath separating the dental papilla, which is here, from the inner investing layer of the dental follicle. It outlines the shape of the root. Epithelial shells grow to demarcate the location of multiple roots. In case of multiple roots, we will have growth of epithelial shelves to demarcate where is the location of the furcation area will be. The Hertwig's epithelial root sheath is responsible for morphology, deciding the morphology of the root, the shape of the root, how long is the root is, how many roots, whether it will be 2 roots, 3 roots, 1 root, the location of the furcation area, and all the details about the shape of the root are decided by the Hertwig's epithelial root sheath. It also induces the cells of the dental papilla in close proximity to the sheath to become odontoblasts. And when these cells, the odontoblasts, are induced, they start to form dentine as pre-dentine first, then the pre-dentine gets mineralized, become dentine. And now imagine hard tissue overlaid by soft tissue. What will happen to the soft tissue? The soft tissue will be torn, and that's what happened to Hertwig's epithelial root sheath. It becomes fenestrated. When it becomes fenestrated, this allows contact between the inner investing layer of the follicle with the dentine, and this will induce the inner cells of the follicle to differentiate into cementoblasts. Then they secrete cementum. So we have the components of the roots now. We have dentine and cementum. Also, there is a layer called the hyaline layer. This hyaline layer is secreted by the Hertwig's epithelial root sheath itself. The dental follicle forms cementum, peridental ligament, and alveolar bone. Inner investing layer forms the cementum, middle periodontal ligament, outer alveolar bone. Differentiation of odontoblasts induced by the inner layer of the Hertwig's epithelial root sheath takes place. Dentine formation followed by separation of the Hertwig's epithelial root sheath. This is called the fenestration or the disintegration of the Hertwig's epithelial root sheath.
once the dentine is mineralized. The root dentine is formed and mineralized. The remnants of the Hertwig's epithelial root sheath are called epithelial cell rest of Malassez. And again, these cells are dormant cells, and they stay dormant in most people throughout life, but sometimes they get activated and form cysts, and these cysts are appear to the side of the root, and they are called lateral periodontal cysts. These cysts should be surgically removed when they are discovered. Differentiation of cementoblasts from mesenchymal cells in the follicle. After the fenestration of the Hertwig's epithelial root sheath, as we said, the cementoblasts come in contact with the hyaline layer and become differentiated into cementoblasts, and then they secrete cementum. Nerve fibers and blood supply. Nerve fibers from plexus below the dental papilla at the cap stage. Nerve fibers form a plexus below the dental papilla at the cap stage. Diffusion into the papilla and the follicle. These nerve fibers are two types: autonomic and sensory. Autonomic, is sympathetic and parasympathetic. Small blood vessels penetrate the papilla at the early bell stage, apparent in the follicle adjacent to the external enamel epithelium, the blood vessels, but they never enter the enamel organ because it's epithelium, and epithelia are avascular. Blood vessels do not penetrate the enamel organ. Epithelial mesenchymal interactions. Both the enamel organ and the dental papilla are required to establish morphodifferentiation and histodifferentiation of the dental tissues. Cytokeratins similar to those expressed by simple epithelia and basal cells of the stratified epithelia. So the types of cytokeratins expressed by the epithelia of the enamel organ, especially the internal enamel epithelium, are similar to those secreted by simple epithelia and the basal cells of a stratified epithelia. This tells us that there is high mitotic activity in these cells, and they are highly active cells. Messages pass between the epithelium and the mesenchyme, and this is called induction. Induction is the effect of each type of cells has on the other, and it's very important for the initiation stage and the continuation of morphogenesis and histogenesis of the tooth. So this epithelium mesenchymal interaction is very important for tooth development. Inductive messages include chemical substances. They are called short-range hormones, direct cell contact, and contact through the extracellular matrix, especially the collagen, the glycoprotein, and proteoglycans that are present between the two layers of the cells that are interacting with each other. Differentiation. The dental papilla is the dominant tissue in both morpho and histodifferentiation, and many experiments proved this dominance. So the experiment that were used to prove this was to put a dental papilla of a posterior tooth and the enamel organ of an anterior tooth together and see what the result will be, what the outcome tooth will be. And the outcome tooth will always follow the origin of the papilla, not the enamel organ. So if you put dental papilla for first molar, for example, and the enamel organ for central incisor, You combine them together, the result will be a first molar. That's why the papilla is considered the dominant tissue. Some clinical considerations. Clinical considerations about tooth development include congenital tooth abnormalities, like any abnormality in during the development of the tooth, any problem in the shape of the tooth, the shape of the crown, the shape of the roots, which is beyond the normal variation, is considered congenital tooth abnormalities. Sometimes the structure is defective. The structure of the enamel, the structure of dentine, the structure of cementum, we have a defect. And this defect is because of the problem took place during the development of the tooth. Then it's called congenital tooth abnormality. So any problem in the tooth that is related to the tooth development, faults and during development, is considered a congenital tooth abnormality. Induction problems. Induction problems leads to missing of teeth. So there is a problem in the induction because it's the very early stage of development of teeth. So if there is a problem in the induction, then we will have a complete missing of the tooth. Splitting or fusing of tooth germs. Sometimes during development, one tooth germ is split into two tooth germs. So we'll have extra tooth. But this extra tooth will be still partially fused to the original tooth. We call this splitting. Sometimes two separate tooth germs get fused together, so we have two teeth fused together. They should be originally separated, and now they are fused. This is called fusion of tooth germs. We also have malformations in shape, size, and number or structure. So the shape might be faulty. For example, the pig-shaped lateral incisor. It's an example on malformation in shape and also size, because it's usually small. Doesn't have flat incisor edge. It has pointed incisor edge. So there is a malformation in shape. And as we said, it's smaller. That's why we have malformation in size as well. Number. Sometimes we have less teeth. We have missing teeth. Sometimes we have extra teeth. Missing teeth, like sometimes we have missing upper lateral incisors. The mostly missing teeth are third molars. Apart from third molars, the mostly missing teeth are maxillary lateral incisors, followed by mandibular second premolars, yes. So maxillary lateral incisors, then mandibular second premolars are the mostly missing teeth. Sometimes we have malformation in structure, like for example amelogenesis imperfecta, which is a genetic defect in the enamel formation, and dentinogenesis imperfecta, which is also genetic defect in dentine formation. Continuing with the clinical considerations, we have macrodontia and microdontia. Macrodontia can be generalized or localized. Microdontia as well can be generalized or localized. Generalized means all teeth. Localized means a single tooth is affected. An example of generalized microdontia, all the teeth are small, is in the case of pituitary dwarfism, where there is a decrease in the secretion of growth hormone from the pituitary gland. And the opposite is generalized macrodontia in case of pituitary gigantism, where there is increase in secretion of the growth hormone from the pituitary gland during childhood. Pig-shaped lateral incisors are examples of localized microdontia, and also malformation of shape, because it has pointed incisal edge rather than a flat incisal edge. Double teeth can be two types: gemination or fusion. Gemination, when the original tooth gem is split into two. Fusion, when two separate tooth gem is fused into one. But whether fusion or gemination, the outcome teeth are not completely split. They are partially, and they are not completely split, not completely fused. They are partially fused at the level of the crown, but their roots are separate. Concrescence. This is one kind of fusion, but not at the level of the crown. This is a fusion at the level of the root. Odontomes. We have two types of odontomes. We have invaginated odontomes and evaginated odontomes, and we'll explain that in a minute. Oligodontia. First of all, we should talk about, in general, about anodontia. We have two types of anodontia. We have partial anodontia and complete or true anodontia. Partial anodontia means we have a number of missing teeth. Partial anodontia, we have a number of missing teeth, excluding third molars. So if you have all your third molars, wisdom teeth, missing, this is not considered partial anodontia. Other than that, even if it's single tooth missing, that hasn't developed at all, congenitally missing, then it's called partial anodontia. And partial anodontia has two terms: oligodontia or hypodontia, depending on how many teeth are missing. Hypodontia, if the number of missing teeth is up to 5, 1, 2, 3, 4, 5, excluding third molars, then it's called hypodontia. If the number of missing teeth is 6 or more, excluding third molar, then it's called oligodontia. Complete anodontia, all teeth are missing, it's called true anodontia. This is very, very rare and only happens when in the extreme cases of a genetic disease called ectodermal dysplasia. There is a defect in a gene that's very vital for the development of teeth. Not all ectodermal dysplasia patients have complete anodontia. Some of them have partial anodontia. A number of teeth are missing. This is only in the severe cases of the disease that you have all the teeth missing. The opposite, we have extra teeth, is called hyperdontia or polydontia. takes place in 90% of cases in the maxilla. And there are two types of hyper or polydontia. We have supernumerary teeth or supplemental teeth. Supernumerary teeth means the extra tooth doesn't look like its neighboring teeth. Supplemental teeth means the extra tooth looks similar to the neighboring teeth. An example of supernumerary teeth is the mesiodense. Mesiodense it is between the upper central incisors, and it's cone-shaped. It doesn't look like the central incisors. That's why it's called supernumerary. Supplemental teeth, two examples of supplemental teeth. Sometimes we have extra premolar, and it's called paramolar. Extra premolar called paramolar. Instead of having two premolars, we have three premolars. And the third one is called paramolar. The most distal one is considered the extra. These two molars, sometimes you have, instead of three molars, you have four molars. And the most distal one is considered the extra tooth, so it's called distomolar. Defect in structure include amelogenesis imperfecta, which is genetic defect in enamel formation. Dentilogenesis imperfecta, again genetic defect in dentine formation. So dentine is formed but it's faulty. Again, amelogenesis imperfecta, enamel is formed but is faulty and can be lost more easily. Hypomineralized teeth, also considered, if it takes place during tooth development, then it's considered a congenital defect. So the enamel, in this case, in hypomineralized teeth, the enamel is completely formed. The enamel is normal, but the process of mineralization is less, whether it's in certain areas of the tooth or the whole enamel. If it's localized spots that are hypomineralized, then they call them enamel opacities. Enamel opacities. Enamel opacities refer to a localized hypomineralization of some parts of the tooth, and they look white chalky. They have white chalky appearance because it's less mineralized. The mineralized enamel, the perfectly mineralized enamel, is more transparent and doesn't look chalky white. Chalky white always means less minerals. Odontomes. We have two types of odontomes. We have invaginated and evaginated odontomes. Let's talk about invaginated odontomes now. The invaginated odontomes takes place when the hydrostatic pressure in the stellate reticulum within the enamel organ is greater than the blood pressure in the dental papilla. So this force will push the internal enamel epithelium to sink toward the dental papilla and leads to formation of hard tissues within the pulp. So it's like formation of dental tissues within the pulp chamber of the tooth. It's called dents in dent, which means tooth inside the tooth. Not a complete tooth, but dental parts within the tooth. So here you see in the pulp chamber, it's wide pulp chamber, and there are hard tissues, dental tissues, enamel and dentine within this tooth. Also, you can see it in radiographs. It's most commonly to take place in the upper lateral incisors, like this tooth here, and associated with a deep cingulum pit. Deep. You remember the palatoradicular groove here? Sometimes we find in the area of the groove we have a wide and deep pit. When you put the explorer, the dental probe, in this pit, it will sink deep. And you imagine the bacteria will go inside this pit and lead to inflammation of the pulp, because this pit is leading to the pulp tissue. Inflammation of the pulp and all the symptoms related to pulp inflammation, like pain. And here in this radiograph you see there is a periapical lesion, a lesion around the apex of the root. This is one of the signs of pulp that this tooth has went through pulp inflammation, and then the inflammation is spread to the surrounding tissues, which is the periodontal ligament and the alveolar bone in this area. So this tooth need to have root canal treatment, so that we can get rid of this inflammation site and bring things back to normal. But this is challenging case. Doing a root canal treatment for such a case is difficult for general dentists, so they are usually referred to endodontist, specialist in pulp therapy of teeth, and they deal with these cases. Here in the radiograph you notice that there's white material here. This is enamel. This is enamel inside. Enamel should be just outside. When you see enamel inside, then this is the case of dent. It's not only enamel, it's also dentine. Enamel, dentine inside the pulp area, and this is typical dent or invaginated odontome. There's histological sections showing dent cases. You see here, in both cases, we see identified dental tissues inside the pulp. Invaginated odontome, associated with exaggeration of cingulum pit formation, so it's wider and deeper. Retarded growth of parts of the tooth germ, active proliferation of an area of the enamel organ into the dental papilla, displacement of part of the enamel organ into the dental papilla. The opposite is evaginated odontomes, so we have extra structure. It's evaginated to the outside of the tooth. This mostly takes place in premolars. That's why it's called young premolar, also called premolar odontomes. This evaginated odontome is interfering with the occlusion, so the occlusion will not be healthy to the patient. Also, there will be rapid attrition, and rapid attrition will lead to exposure of the pulp horn here, as this odontome has pulp horn in the core, and this will lead to pulp inflammation. So the best thing to do, as soon as you identify that there is an evaginated odontome, the best thing is to remove the odontome. You will do pulp exposure, but that's not a problem because it's a clean environment. When you do removal of this part under within a clean environment, there is no problem. And then you put a cap on the pulp called direct pulp capping procedure. You put a cap in the form of calcium hydroxide or MTA, then you put a temporary filling, and you wait for 2 weeks. If there is no symptoms, the patient doesn't complain from pulp inflammation within this period, then you can proceed to make the permanent filling. If there is symptoms of pulp inflammation, then you have to do root canal treatment. Now we'll talk enamel pearls. Enamel pearls are enamel, extra enamel, found accidentally in the furcation areas of roots of teeth. For example, you take a radiograph and you find enamel, like a ball of enamel, circular structure of enamel in the furcation area of the root, because enamel appears whiter than cementum, whiter than the root. So you can identify it as a whiter spherical structure in radiographs, and this tells you that this is enamel pearl. There is no complaint from this. It doesn't make any problem, and you don't need to do anything for it. It's a small droplet of enamel on the root near the furcation. The reason why it formed is thought to be due to the budding of the Hertug's epithelial root sheath. Meaning, budding is the splitting of the internal enamel epithelial layer from the outer enamel epithelial layer of the Hertug's epithelial root sheath. And when they split away from each other, they retain their original structure, which is stellate reticulum in between and the stratum intermedium. And this will return back as the structure of the enamel organ, which have the ability to secrete enamel. So budding of Hertug's epithelial root sheath and differentiation of ameloblasts. Thank you very much for listening. We appreciate your time and patience. And next week we will talk to you about salivary glands. And the week after, the last lecture, which is about the temporomandibular joint. Look after yourself, stay safe and healthy, look after your family, and wish you all the best. Take care. Bye bye.